Chest syndrome in sickle cell disease. Scenario: a 19-year-old student with sickle cell disease presents to the emergency department. He reports a 2-day history of cough, fever, and increasing shortness of breath. Over the last few hours he has developed pleuritic chest pain and his breathing has rapidly deteriorated. The nurse tells you he is hypoxic with a tachycardia and is becoming distressed. Introduction. The fundamental problem is that of sickling of red blood cells within the pulmonary circulation, which leads to reduced perfusion and gas exchange in the lung, causing local hypoxia and acidosis. As the patient becomes more unwell, he becomes dehydrated and his blood viscosity increases. Pleuritic chest pain may cause segmental hypoventilation and exacerbate hypoxia, which together with increased viscosity and acidosis all promote further sickling of red cells. A vicious circle is set up, leading to rapid clinical deterioration. The initial trigger may be infection within the lung or bony rib infarction. Repeated sickling within the lung eventually leads to pulmonary damage and an increased risk of embolism. NB. Acute chest syndrome is one of the commonest causes of death in adults with sickle cell disease. This is a medical emergency and without prompt and appropriate treatment this young man will die. History of the presenting problem. The clinical features of chest syndrome are shortness of breath, pleuritic chest pain and fever. These can make it difficult to distinguish from pneumonia or pulmonary embolism, PE. The patient may not be able to give a clear history of their condition, because there is often no obvious trigger. In this case, a chest infection may have initiated the process by causing local hypoxia. Ask the patient about features that would suggest pneumonia, e.g. travel, hotel rooms. This might make it worth considering Legionella, rigors, and colored sputum. Ask about features that would suggest PE, such as previous episodes, risk factors, unilateral leg pain and swelling and hemoptysis. Other relevant history. Has the patient had previous sickling episodes, and what were they like? In particular, has he had chest problems before? What is his vaccination status? Presuming that he has a non-functioning spleen, this would mean there is a particular risk of pneumococcal infection. The family history is relevant as patterns often follow through generations. Examination. General features. Rapid assessment and resuscitation are required. Check the patient's airway, breathing, respiratory rate and pulse oximetry, circulation, peripheral perfusion, pulse, and BP, and their position on the Glasgow Coma Scale. Is he in shock? Examination, respiratory system. Look for decreased chest expansion, consolidation, or a pleural rub. Rib tenderness may be a feature. Investigation. FBC. Look for normochromic, normocytic anemia with sickle cells. Neutrophilia occurs with or without infection. Thrombocytopenia and reduced packed cell volume may occur as a result of sequestration within the pulmonary circulation. Thrombocytosis may occur in autosplenectomy. Biochemistry and arterial blood gas analysis. Check electrolytes, renal and liver function and blood glucose. Measure arterial blood gases to confirm the degree of hypoxia and look for acidosis. Microbiology. Culture his blood, urine, and stool. Send his serology for respiratory pathogens. Radiology. The CXR may show widespread patchy infiltrates that are difficult to distinguish from infection. Management. Oxygen and intravenous fluids are essential. Sit the patient up and give high-flow oxygen through a rebreathing bag. Place intravenous access in both arms and rapidly infuse 1 L of 0.9% saline. Start intravenous antibiotics, e.g. ampicillin 500 mg for 6 hourly. If the patient is in pain, administer analgesia. Intravenous opiate, e.g. diamorphine 5 mg, is the most effective agent, but use with caution as it may cause respiratory depression. Consider patient-controlled analgesia once he is medically stabilized. Administer enoxaparin 40 mg SC once a day as prophylaxis against venous thromboembolic disease, or therapeutic anticoagulation if PE is strongly suspected. NB. Severe crises, which require management in an intensive care unit, are indicated by reduced level of consciousness, persistent hypoxia, unstable or deteriorating circulation/breathing. Further comments. Few GPS in the UK are experienced in the management of the complications of sickle cell disease. All cases should be discussed with a hematologist who has the necessary expertise. Chest syndrome with hypoxia, neurological symptoms, or priapism are all indications for exchange blood transfusion, the aim of which is to reduce hemoglobin, HB, S to less than 30%, i.e. an HbA of greater than 70%. Following complete recovery, the use of hydroxycarbamide, hydroxyurea, might be considered. This drug increases fetal HB, increases mean corpuscular volume and reduces the white cell count. It significantly reduces the number of crises, without appearing to be leukemogenic.